This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, I'm Dr. Deepak Megur, and today we're going to learn a little bit about RHEXIS rescue maneuvers and what are the common mistakes why a surgeon is going to do when he or she is planning to rescue the RHEXIS. This is an intumescent lens, and a beginner phacosurgeon is performing RHEXIS. At some point, the surgeon does feel that the RHEXIS is getting out of control. Let me pause the video here. The corneal folds indicate that the chamber is shallowing. The probable reason is the cystotome is bending on the posterior lip, letting out the OVD, the AC is shallowing. This is the situation which actually leads to RHEXIS running towards the equator. The surgeon has realized this and tries to correct it. So he's trying to pull it back, and you can see the desperation in the movement trying to get it back. But it is not listening, and it is heading more towards the equator. Better sense prevails with the surgeon. She comes out and she refills the chamber with OVD. So in this freeze frame, we can still see that the tearing edge of the RHEXIS is still about 2 mm away from the equator. There is a good possibility that the RHEXIS extension can be prevented, provided we follow the right principles. Let's see how it turns out. The surgeon now goes in with the forceps, which is the right thing to do, and now is attempting the Dr. Little's maneuver of pulling in the flap to rescue the RHEXIS. But unfortunately, the rescue maneuver was not successful. She goes in and tries with a micro forceps from the side port, but it was too late for us to rescue it now. Since it's not possible for us to retrieve the RHEXIS back, the flap is cut with the micro forceps, and then the remaining tear is completed. So we have a weak area in this region. Now is the time to analyze what went wrong with the rescue maneuver. Okay, the first principle to follow when we want to rescue a RHEXIS is that the capsular flap has to be flat. Now in this case, please note that the capsular flap is still folded, and with a folded capsule, the surgeon is trying to rescue it. It's not going to work. Number 2, when the surgeon is trying to hold the capsule, please note the corneal folds. It indicates that the chamber is again shallowing, and this is probably because the forceps is pressing on the posterior lip of the incision, which is letting out the OVD, and a shallow chamber is the primary risk factor for an uncontrolled RHEXIS. The third error, please look at the direction of the pull. The direction of the pull has to be towards the center of the eye, that is the centripetally, but in this case the surgeon is trying to go around it, just like how we do in a shearing technique, and that's not going to work. The fourth error, it would have been better if the angle of attack was from the left side port, so that we could have kept the flap flat and then pulled it centripetally. And since we're using a side port, there's always a risk of losing the chamber is also minimal. So that would have been a better approach probably. So now let's go back and see how it's the right way to do it in a couple of cases. Now this is an intumescent cataract, and I begin by making a smaller RHEXIS, but I feel that I'm in good control. I want to make a larger RHEXIS. I try to increase the diameter, and at this stage I feel that the RHEXIS is now getting out of control. So early diagnosis in the change the trajectory of the RHEXIS tear is probably the most important factor. So once I realize that, I just pause for a moment and then make the capsule flat here and then pull it centripetally. So let me replay the movement in slow motion. You can see the capsule is held flat and my forceps is moving away from the direction of the tear. It is directed towards the center of the eye. This is the maneuver which is going to rein back the RHEXIS in. So the tear is back in control and the RHEXIS could be completed. So the key points is, first is to diagnose it early, and second would be to ensure that your maneuvers are right. Now moving on to the second case. So this is an immature cataract, but in the subincisional area, the RHEXIS is now threatening to run away. Timing of the diagnosis is extremely critical. The first thing we need to make is, again, make the capsule flat when you're trying to maneuver and inject the OVD above the capsule, not under it. This ensures that we are not increasing the intralenticular pressure by putting in the OVD within the capsular bag. Obviously, this injecting the OVD above the capsule has also made it flat. Now, the next point of consideration should be what should be the angle of attack. Should I continue to go ahead and use the main incision, or should I change the angle of attack, use either of the side ports? Using the main incision might not be the best approach in this case. So, the reason is you don't have good access to the tear because it's subincisional. Second is when you're trying to maneuver forcibly, there's always a risk of losing the antechamber. So in such situation, it warrants that we use the other side port. Having a good pair of microforceps does come in handy. So I introduce the microforceps to the left side port, keep the capsule flat, and please note the direction of maneuver. It is going to be pulled towards the center of the eye. And we're successful in retrieving the RHEXIS back. One more important point I would like to stress is when you're trying to pull in the flap, our maneuvers have to be firm and quick. This ensures that the tear is controlled and it comes back inside the equator. Moving on to the next case, the case is going on well. It's under topical anesthesia and suddenly the patient moves his eye and we have a situation where the RHEXIS is threatening to run away. Again, please note the same principles are to be followed. We want to refill the chamber with OVD. At this point, it's important again to re-emphasize that the OVD cannot be pushed under the capsule. It has to be pushed above the capsule, preferably in the peripheral part of the antechamber, and this OVD is going to flatten the capsule. The first principle is to flatten the capsule, and again now the tear is in the subincisional main area. Now again the question is what should be the port which you are going to use to rescue the RHEXIS? Since the tear is just under the main incision, I would avoid the main incision and choose one of the side ports. So in this case I'm using the right side port. Another point to note here is that since the patient is anxious and moving the eye, so I want to stabilize the globe. Fixating the globe with the second instrument is extremely critical so that the eyeball doesn't move again. And now I'm going to try the rescue maneuver. Again, the forceps of choice is the microforceps. The capsule is held flat and then pulled centripetally, that is towards the center of the eye, and we could very well rescue the RHEXIS. So to summarize, the important points to follow when we are threatened by a situation where the RHEXIS is hinting to run away. The first thing is always to diagnose this very early because timing is extremely critical. Always refill the chamber with the OVD on top of the flap and not under it, and preferably in the peripheral part of the chamber, not in the center part. Number 3, the most important principle which most novice surgeons forget is to ensure that the capsular flap is laid flat. So all our maneuvers are going to start only after the capsular flap is going laid flat and it should not be folded. The fourth important point is identify the right angle of attack to do the rescue maneuver. By this, I mean that you should have absolute control and also be comfortable in accessing the flap. And lastly, when you're trying to do the rescue maneuver, it's always easy to do it with the forceps rather than the needle. And use a good forceps to do this. So that was it. Thank you for watching and hope you found this helpful.